right, talking to me, like, making sense. She looks like a normal 42-year-old female. No, yeah, it's a good question. Like, smiles, like, give me a big toothy smile. Yep, holds her hands up. I think I did some other neuro stuff, fixes and follows. She's making total sense. She's just got a headache, posterior headache. Any other information? You guys want to dig in on this diet pill? I don't know. She wouldn't tell me what it was. I just assumed it was like phentermine, but she wouldn't confirm or deny. And I don't have any of her stuff because she's from North Carolina. Yeah. Nope. No, good question. So up here in front, my buddy said, is it the worst headache she's ever had in her life? Nope. So not the worst headache. No nuchal rigidity, chin to chest for me, right? So she didn't have any meningeal signs. I didn't do Koenig's or Brzezinski's, but I mean, she's made headaches. No, no previous history of headaches. No aura. Any visual changes? So she tells me, and I think it's on the next slide, that I look blurry to her, but I get a visual acuity, and it's 20/20, left, right, both. I'm like, I look blurry. Okay. What's that? You guys are like, this is neuro. We know where this is going, right? Posterior stroke, right? I try to give you guys these because, like, when you spin somebody or like get a CT, like, be prepared for what you're looking for. But physical exam, like, she looked great. So ANO4, well developed, well nourished, no acute distress. NIHS 0, we talked about that. Negative hints, head impulse, nystagmus, test askew. So I looked at her eyes, no nystagmus. She wasn't dizzy, no vertiginal, vertigo type symptoms. Cranial nerve 2 through 12, grossly intact. Yes, I didn't do one. Heart and lungs unremarkable. HENT unremarkable. Visual acuity 20/20 ODO SOU, like we said. And she just says, you look funny. I'm like, yeah. I've been told that a few times. But she's like, you look kind of fuzzy when you walk in the room, and then as you get closer. So I'm like, man, eyeglasses? Like, the eye strain? Like, started going down that trap. 42-year-old, well, we're in the ER, so what do you guys want to do? Don't know the truth, put her in the answer box. How many people want to put her in the answer box? CT, non-con? How many people don't know what they want to do? Anything else you want to do? Well, let's think about it. Let's talk about it as a class. What are some other things? We're in the ER. Now remember, I'm not the guy to get mad at you. I'm just the guy to say, like, why do you want to do that? Anybody want a pregnancy test on her? 42-year-old female? Why not? Why not? Anybody want a CBC, CMP? Why not? Right? Right? So you say, why? Why am I ordering that? Why am I ordering a CBC on a 42-year-old with a headache, posterior headache? Sure. Right? I don't know. Infection, I can prove that she's not anemia. That's what I want you guys to think about. Like, it'd be a weird presentation for anemia, but at least I can check her H and H. CMP, check her electrolytes. I don't know. She's not, I don't want to say she's a poor historian, but she's not giving me too much, and I have no chart to go biopsy. So I'm like, yeah, whatever. Like, CBC, CMP, pregnancy test is a good starting spot. Treat her. Do I think if this is a weird presentation? Because how many people have, I don't know, migraine, tension? Are those in your differential? We haven't talked headaches yet, but they should be. Headache, right? She's coming in with a headache. They're like, what's wrong with you? I'm like, I don't know, you have a headache. She's like, nice, you're like the smartest guy I've ever met. What type of headache is it? I'm like, I don't know yet. It's just a headache until we figure out. Sir, in front.
Were you only appearing fuzzy when you moved, or is it when you're standing still?
It was when I was standing still as well. Yep. And then the other question I said yesterday we should always ask, but I neglected, is trauma. Any recent slip, trips, or falls? I don't know. She's visiting from North Carolina. Maybe they're getting rowdy. She was drinking last night. I asked that. Were you out partying? No. Did you slip and trip and fall? You just don't want to tell me? I don't really care. So physical exam was totally benign. Like, everything was great. Back of her head felt fine. She had no pain.
How far did she travel from?
Palpation.
Maybe she was on a long flight.
Yeah, North Carolina a year.
Oh, it was a year.
Yeah. Where are you going with that one?
I don't know, just like long flights, maybe.
Birchhouse Triad.
It's a clot. It's a clot.
Well, so that's what I thought. I was like, are you thinking DVT PE that went upstream? All right, cool, man. I'll buy it for $1. Like, if you're selling it, I'll pick it up. But I mean, definitely when I initially hear someone come in to the ER and they're like, I flew in here, that's automatically something I'm like. Clearly, if she's like, unilateral leg pain, hemoptysis, and so, I'm like, oh shit. Your PERC score is really high, but could be a headache. I don't know. Yeah. What else? So we got labs cooking. You want me to order a CT scan?
You can do EKG.
We can do an EKG. Looks great.
Did she have any abnormal, like falling backwards, like
No.
spatial surges
No.
or?
Nothing. Nope. No, that's why I was doing hints. With your hints exam, we talk about later in stroke, is I'm turning her head abruptly, having her look straight. I'm trying to see if her eyes, if she gets any vertiginous symptoms or dizziness or eye changes. Nothing. Literally like a nothing burger. No nystagmus. So I'm getting basically a posterior headache. Spinner? Yeah, we'll spin her. Yeah, hell yeah. In the interim, I think I was like, you know what? It sounds like a headache, so we're going to treat you for a headache. So how do you think the Toradol did for us? Oh no! I actually, so typically with them, I'll do IV Tylenol. So I think I did a gram of Offermed, which is IV Tylenol. It's just an expensive version. Some Zofran and some Benadryl. So now I just made my brain bleeder just really tired. Yeah, perfect. She can't bitch about anything else anymore. But why? So what's going on? So posterior. We'll link this to neuroanatomy. What's back here? Occiput. So where do our visual cortex lie? Back there. Weird, right? So I think whoever invented us, whoever you guys or whatever you guys believe in, did a pretty damn good job, except for this to me. Like the eyes all the way back, desiccating and chasing all the way back here. Does anybody ever fall back and hit their head and everything goes fuzzy for a second? Yeah. It's like, I don't know why it's back there. Like, move it up, right? Move it up. I haven't figured out how to do that. So she's got a brain bleed. So for those folks wondering, what the hell am I looking at? 2 slices of a CT. I think I have some where actually I scroll through them and you guys can see them a little bit better. But positive brain bleed here, right? So that's not good. So I get to go in and tell her. And once I told her and showed her, how do you think her demeanor was? Yeah, I was like, hey man, I'm gonna sit down. Like, so I got some news. I think I know why you have a headache in the back of your head. Your brain is bleeding. And she's like, what? Like, yeah, you've got a brain bleed. So I think yesterday when your blood pressure was 220 over 50, you popped a vessel in your brain. So she's like, holy shit, like, what do I do? And I'm like, well, you go to the hospital, you're there. So we're gonna call a neurosurgeon. He's right here. And it was great because I didn't really have a whole lot to do other than antiemetics, which I had on board, plus or minus some Keppra, because I don't know if that's going to cause her to seize. She wasn't. She looked great. But I was like, why not, just to be safe, give her a gram of Keppra. And then call a neurosurgeon. Neurosurgeon was like less thrilled about it. They're like, yeah, we're just going to watch it. And I'm like, okay, that's a neat option. Can you sign this chart for me with your initials? And they're like, yeah, you can discharge her. I'm like, no, I can't. PA Rogers, you're the MD, brother. But. All right. Functional neuroanatomy. So again, I say that case and the case yesterday. So we talked yesterday about kind of mapping some of the brain and how it, how your patient presents to you. So in the back of my mind, I honestly, with that individual patient, I wasn't really, my clinical index of suspicion wasn't super high for a stroke. It probably should have been, and I'm glad I found it. But the only thing that would really have tipped me off was like she's saying that I'm fuzzy, but her visual acuity was fine. So I can't really put that one together or understand it. That's just why I share it with you guys. So again, if that's something you're like, oh, it all makes sense in the end when I get the answer. And I'm like, oh, I know why I'm blurry. Like your visual center is like the brain tissue is getting bled upon. Like that's suboptimal for your visual input. So okay, functional neuroanatomy. You guys, this is the lecture where I said you guys are gonna like see a bunch of A&P slides from semester 1. Don't freak out on me. Like we'll get you through it. But we need to map the brain. We need to look at which parts of the brain control different areas. And why do you guys think that's important? Just to ask the captain obvious question. So why would I want to know which part of the brain affects which part of the body?
Situation like that.
That may be your only clue, right? That may be your only clue. So again, backwards engineering the case I gave you, sure, it's easy for you guys now to say, like, of course it's I knew you were going to give us a stroke. Blurry vision, it's got to be in the back of the head. Come on now, wake up, right? Makes sense now, but that may be the only tip or clue you guys get. So. All right, what does the CNS, PNS do? Someone give me their own, I want you guys involved. No takers, all right. So it receives information, right? It analyzes it and then it makes a decision. Does that sound fair? I mean, that's what it says up there, right? So sensory, perception of the world around us, what's going on, goes up to your brain makes a decision, and then you action it. Is that fair to say? Action being movement, getting out of the way, like someone throws a baseball at you and you're like, oh shit, there's a baseball coming at me. Goes up to your brain and you take a step to the left and either or catch the baseball. So is everybody familiar with like Tactical Operations Center, like a TOC? Right? So I'm not here to teach you guys Army doctrine, but essentially it's the TOC. It's the Tactical Operations Center of the body. So there we go. Moving forward. Next slide. CNS, PNS, you guys already know this. Central nervous system, or the CNS is the brain, spinal cord. Everything else is your PNS. How far do you think your nerves will stretch length to length? This is going to be good. I'm going to get some crazy ass answers, I guarantee it. So if you took all your nervous tissues and strung it out,
It's around the world.
20 feet around the world? God damn, man. He's smart, dude. What do you guys think?
To the moon, 2 miles.
That's all your blood vessels. That's your
All
blood
right, cool.
vessels.
I don't know the answer. I'm just asking. I'm just asking.
Ask for it.
I think it's either 40 feet or 40 yards. I can't remember. So, what am I talking about? You guys all have Google. Someone Google that for me and correct me. If it's to the moon or around the world, I'm way off. But I think it's less than a football field. But anyways, you've seen ortho probably puts up 207 bones and they're like, this is it, right? And all its infamy. Like you look at the nervous system, it's actually to me, I thought initially when I saw it, was kind of intimidating, just because it looks almost like alien-esque. Anybody find the answer? You're just like, nah, we're just gonna ignore them. 45 miles? Holy shite, I was off. 45 miles. 45 feet, 45 yards, 45 miles. Anybody know how many feet in a mile?
260.
Y'all know that stuff though, right? From like 5th grade, right? Yeah, good stuff.
It's not around the world.
All right, 45 miles is way off from what I thought. That's insane. That's neat. So, wait, am I supposed to be teaching you guys this stuff? That's what I thought. That's the right answer. All right, developmental neuroanatomy. We just watched the video. So again, I don't need you guys to know and memorize neural plate, neural grooves, neural folds, neural tube. What I need you to understand is this happens early. So yep, it's broken up in the marginal, mantle, ependymal layer, or the outer, middle, or inner if you're a Bostonian like me. And then you can see that the crest divides into basically everything in the PNS, right? So what's the big deal here? What's the takeaway? Let me get through these first. This is it, right? So we're trying to avoid this, our neural tube defects, which we'll talk about 3 of them. We'll talk about anencephaly, encephalocele, and meningiomyocele, right? So how do we do that is folic acid. We just went over the answer in that video that everybody watched. Does you have a burning desire to take out the trash? Respect the cleanliness, man. Like, cleanliness is next to godliness. Good luck. Yeah, I appreciate it. I feel loved. So, when does this happen? When does the formation? Let me go back. I told myself I wouldn't go back. Early, first month, first 28 days. I have not yet been a pregnant female, but do pregnant females generally know that they're pregnant within the first month? Maybe. Yeah, that's a loaded question. Yeah, if they're trying, but if they're trying, they should probably be on folic acid supplementation anyways. So that's family planning where you guys come into family medicine. So talk to your young females of childbearing age, and if they're trying to get pregnant, then offer a prenatal vitamin or folic acid supplementation. So a lot of times the concern is they don't know. I know for at least our 2 kids, I mean, I don't know if I want to say this out loud. I feel like we know each other well enough, but serendipitous surprise. Like, it wasn't like I was trying not to. Yeah. But we were out living our best life, right? You know, and you're going out having a couple drinks, and then we find out we're pregnant after, and my wife's like freaking out, like, I'm going to kill our kids, right? Oh, I had no idea. Which, you know, luckily, knock on wood, they're okay for the most part. But had we done that better and maybe thought about family planning instead of just attacking with our backside, we would have been a little bit better off. So All right, three main types, yeah. So in anencephaly, so failure of the anterior neural cord to close, right? So cranial bones fail to develop and the brain degenerates. So that's a problem for us. Myomeningeal, which is way, you can see spina bifida. Anybody know anybody with spina bifida or seen spina bifida outside? So you've probably seen patients or folks with it walking around, but you probably didn't know maybe that it was that, or this kind of, again, that or CP, cerebral palsy can kind of, you guys probably may not know, that's not a neurotube defect, but that's usually trauma around birth itself. But you're like, I don't know why that person has that gait or walks like that, and maybe CP or something. Anyways, so folic acid supplementation, star this, you'll get a question on it. I don't know if I'll give you the question on either low risk or high risk, so I'll let you guys know in the review. But either way, I do think it's important that we know that folic acid is there. We know that the studies have been done, and we know that it helps prevent NTDs. Okay, it's enough said on that. So that's the list from up to date. If you don't believe me, you guys can zoom in on it. But I'm telling you, for low risk, 0.4 milligrams. High risk, which high risk is previous pregnancy affected by a neurotube defect, either parent with neurotube defect, child, or and you want to start supplementation a little bit before, so 3 months prior and a higher dose. So know the doses and know the high risk stratification for that. If you're like, what exactly do I want to know? Stay tuned. I'll get you guys on the backside. All right, major parts of the brain: brainstem, cerebellum, diencephalon, cerebrum. Is this new to everybody? Everybody feel okay with this? So we're going to kind of map the brain a little bit here. So I want this to be reviewed for you guys, but if it's not and you're like, whoa, that's not what we talked about, raise your hand. And I'll tell you guys, for the folks kind of studying along as we go, I'll tell you what I want you guys to focus on. So, the brain stem we talked about yesterday, right? So medulla oblongata, yes, I finally got to say that. Does anybody know why crocodiles so honoring? Yeah. My mama says crocodiles are so ornery because they got all them teeth and no toothbrush. Does anybody not know what that's from? Really? The water boy? So just Google, okay. My God, so if you don't know what that's from, you must be like, what the hell is this guy talking about? It's insane. So just Google the water boy and that scene. Anyways, it has to do with their medulla oblongata. We're not going to learn about crocodiles here. Thought to be a proponent in like rage and emotion, right? So also the pons in the midbrain. I just always, when I knew they told me I was taking neuro, I was like, I'm going to say that every single class. And half the class now, as I get further along, are like, we have no idea what the water boy is or what you're saying. So, it just means I'm old, I guess. What I'll do is we'll take a break and I'll bring it up. That way, so we're all, no, we're doing it. So that is the one thing I want to impart on you guys here. It's a great scene. He drop kicks the professor. Don't do that to me. So. All right, the cerebellum is the small brain, right? Responsible for what? Fine movement, right? Walking, balance, coordination, all that stuff. Dude. We talked about that yesterday. So the diencephalon, thalamus, hypothalamus, what do those do? Right, regulators. Nothing? I don't know. Warren G? I just, man, I feel like I'm not hitting. Somebody, thanks, man. Yeah. All right, moving on. What's this cerebrum do? That's your executive suite or your higher headquarters, right? So what does that do for us? Decision making, excellent, good job, right? So decision making, calculations, stuff like that. So the cerebral cortex divided in different lobes that correspond to the bone that sits in front of them. So if you remember the bone, awesome. Just remember the lobe that sits underneath it that it protects. So that's going to be helpful to you as well. So we know that it divides, right? So the corpus callosum is where it crosses. We know that the left controls right, right controls left. Is that fair? That's going to be important for us when we have stroke discussions. And my hand's doing this. And you're like, I think he has a left-sided stroke. You're like, wait, no, I don't, because I know this side is controlled by this, right? So you want to make sure you're articulating that or looking for right-sided MCA issues instead of left. So, corpus callosum, communication between the two. Interestingly enough, There's some seizure disorders we'll talk about, and maybe the next lecture, the one after that, like refractory seizures to meds and some other brain stimulation treatments. They'll cut the corpus callosum. So what happens if I cut the corpus callosum? You're like, they don't talk to each other? Yeah, I just told you it's the communication, but you think you could get personality changes? Yeah, it can change a person's entire demeanor. It can also help with seizures. So we're not doing that. That's not in family medicine practice. Please don't try to do that in your clinic. That's going to be somebody that neurosurgery is going to be doing that. So. Okay. Yes, a lot of words, a lot of writing. Circle, bottom right. It's distilled down for you, at least on my screen it is. I would like you to know that the frontal lobe is responsible for behavior, emotions, problem solving, personality, reasoning, and it's the primary motor region on the precentral gyrus. Okay. Another thing that would be good to know if you're studying this over the weekend is Baroque speech area, which is located in the frontal lobe as well. Which, do we remember Baroque's? Broken speech, BD, right? Broken speech. So I think you guys watched some videos. I was showing for the longest time, and then the class was like, we've already seen these like freshman semester. Did you guys see it already? So I'm like, yeah, I'm not going to show them anymore because I don't like wasting time. So. Temporal lobe, language, hearing, short-term memory, and olfaction, right? So, olfaction, excuse me. So, what is olfaction? Smell, right? And remember, smell and gustcation and taste are kind of yoked. So, just remember that when we're thinking about cranial one stuff. But we talked about Baroque's frontal, so temporal. We're talking about Wernicke's, I was going to say encephalopathy, but word salad, right? So, jumbled words. What does that sound like if you see somebody with word salad? Anybody want to give a swing? Yeah. Yeah, you're making words. They just don't have any meaning, right? So they don't have any meaning. So have I seen this out there? Yep. Have I seen it and been like, that's Wernicke's? Nope. I usually, like I told you guys, my wife was a ICU neuro nurse, and I would go, like when I first started teaching neuro, I'm like, man, I'm going to go hang out at your work and see some of this stuff and see if it really exists. And I would see like the sick of the sick patients, and she'd be like, oh yeah, they have this, and I'd be like, I see. And they were super nice. I told you guys, one of the neurosurgeons was a IPAP. He did not get accepted into IPAP. So when I saw him, I was like, hey man, you want to come guest lecture? He's like, no, I hate your program. And I'm like, nice. I do too. Yeah, same thing. He's like, no, I didn't say that. And he's like, I applied to IPAP and they wouldn't accept me. And I'm like, well, look at you now. Like, you're a neurosurgeon. Like, you may not have been a neurosurgeon. He's like, whatever, man. If I wasn't good enough for you then, I'm not good enough for you now. And I'm like, okay. I'm like, calm down, buddy. But anyways, he's actually a really good dude. And he showed me a bunch of pathology. He showed me a bunch of EVDs. And I'm like, okay, let me back up for a second. I didn't just go in there as like, hey, I'm her wife. I'm her husband. Can I just see you drill someone's head? I was credentialed in that hospital. So I worked in the ER. So I got to know this guy. We were talking to each other. And he's like, yeah, if you ever want to see anything, come by. So like we would get to hang out and see some of his procedures. So if you're like, I could just go into a hospital and be like, I'm a PA, I want to do this. They'll be like, get out. You get your ass rolled up pretty quick. But God bless you. I'm starting to think you have an allergy problem.
I think so.
Yeah. Do you take anything?
No.
Okay. Cedar fever is big.
Full workout.
All right, full workout. Yeah, it could be a stroke. No, I'm just kidding. I'm just kidding. That's messed up. All right, parietal lobes. Again, circle the bottom right. Asterognosis, hemispatial neglect, inability to copy theory. What's asterognosis?
No clue. I didn't know that was a word.
Yeah, good. So how do I test that?
What did you just say?
Close your eyes, right? Close your eyes and put what in my hand? Keep your mind out of the gutter. Yeah. How about like a key or a pen? Yeah. Don't put some crazy stuff in there until like, I don't know what this is. You guys thought I was talking about something else. No, we ain't going there. So parietal lobe, I'd like you to know that. Occipital lobe, visual processing, shape and color identification. So again, my lady in the beginning, blurry vision's all I got, and her visual acuity was pristine. I didn't test her on shape and color identification. Shame on me. I wasn't like, what color's this? What color's this? Like, yeah, you can do that though. You can do that if you want. So, yeah. Hemispheric lateralization. What does that mean? It means that you guys sitting here right now are either left or right dominant in your brain. Anybody care which side they are? Why would you? Like, it works together in tandem, right? Unless you have some sort of atrophy of a portion of your brain. But so the population largely, if you look it up, is usually left dominant, which is responsible for language, speech, calculation. And you guys can see there, non-dominant, right, is usually responsible for the following. I'm not going to read it to you, but it's actually pretty neat because I think one class somebody asked me, like, what's the actual breakdown? And it's not like 70-30, 80-20. It's something weird where it's like 40-30 and then the rest are both. And I'm like, that's really inconclusive. But so just for our discussion, you will be either left or right dominant. Per the literature, you're mostly left dominant, left-handed, left brain dominant. So neurotransmitters, what does a neurotransmitter do? Did you guys say chemical messenger? Is that a good answer? Yeah, sure. Do you guys remember some of these? Yeah, I'll keep you out the weeds on the ones I want you to know. If it says most common or something like that, you can circle it right now. But talk acetylcholine. Acetylcholine, largely responsible, you guys remember, like muscle contraction. So for our principles in the PNS and CNS, it can either be excitatory or inhibitory, which is kind of neat, I think, if that's your jam. But dopamine, what do you guys think about when you hear dopamine? Parkinson's. Yeah, usually like a feel-good neurotransmitter responsible for kind of like addictive behaviors, pleasure experiences, right? So you see decreased dopaminergic action in Parkinson's disease, which we did later, and then increased in schizophrenia, which is kind of neat. Norepi, you guys remember this one? This is your most common neurotransmitter. They're postganglionic sympathetic neurons, right? So there's this catecholamine hypothesis of mood disorders. I'm not going to test you on that. I bring it up because I think it's kind of neat. Does anybody remember talking about this in behavioral health? Do you guys remember SNRIs? SSRIs, SNRIs? So do you remember what does norepi do? What does norepi play a role in? It can. I mean, if we're giving them a selective serotonin norepi uptake inhibitor, what are we trying to do?
Maintain norepinephrine.
Right, so we're slowing down the breakdown. That's oftentimes people are like, I'm going to flood you with this. You're not flooding anybody with anything. You're slowing down the breakdown. So the catecholamine hypothesis of mood disorder states reduction of norepi is related to depression. So, and you guys remember learning about, so the enzyme that breaks down catecholamines is monoxamine oxidase, MAO. So you guys remember MAOIs? Which I don't think I've ever seen anybody prescribe one of them, maybe like old school folks. But again, that's why we learn the mechanism of action in your pharmacological studies. So norepi, good for mood, right? So if we don't have any, or it's, let me look at that. So serotonin, 5-HT, what's serotonin? Yeah, that's a good one. So think about it as the happy molecule. So of note, low brain serotonin levels don't directly cause mood disorders, but rather create a permissive environment that allows other factors such as dopamine, norepi, and environmental stressors to trigger depression or mania. So it's a little bit more in depth than I want you guys to know, but you'll notice when you guys are prescribing out there, how many folks think they're going to be treating anxiety and depression? Yeah, right. Some people just didn't want to play, but I'll just assume you raised your hand. Come on, man. Thanks. Yeah, absolutely. It's going to be your wheelhouse. So SSRIs, SNRIs, and that's not my scope, but you guys remember that stuff. So, all right, GABA. Yeah, circle GABA. So GABA is the major inhibitor neurotransmitter of the brain. So GABA is going to be a neat one for us. So if I increase GABA, what do I do? Inhibit. So if I increase GABA, which like I give somebody a benzo, it's going to do what to GABA? But if I give someone a benzo, I'm going to increase GABA, which does what? Inhibits, right? So if I take a drink of alcohol, it does what to GABA? It increases it, right? So a lot of folks last class were like, I don't get it, right? It's like, I'm like, you're taking a drink, GABA's going up, but your mood's going down. I'm like, yeah, you're getting it. Like, you're telling me exactly what I'm expecting you to know. So I do want us to know a lot of medications that we talk about, benzos, right? We talk about seizure disorders. Like, this is what we're doing, right? So we're increasing an inhibitor, which is causing inhibition. Does that make sense to everybody right now? I told you guys are better than the last class, but they were like, no, it doesn't make sense. Explain it. And I'm like, do you want me to interpret dance it? Like, I don't know what else to say, but okay. Glycine is a major inhibitor of the spinal cord. So GABA, the brain,
glycine in the spinal cord, and then glutamate is the excitatory one of the brain. Okay, so you guys, you're like, what the hell? Like, what do you want me to know out of this? Like, I'm going to tell you guys when we get closer, but I would, if it says most common, take a look at it when you're studying. Okay, so the most commons really, and that's just not a Rogers testable thing. That's something that you're going to get pimped on, right? So someone's going to take you aside in phase 2 and be like, explain alcohol and what it does to the neurotransmitters in the brain. And I don't want you guys to be like, Rogers didn't say that. He just gave us the answers. That's not helping you out. I mean, it's helping you out 50-meter target, but I'm failing you in the 300-meter target. Does that make sense? Okay. Am I still going to give you? Yeah, probably. But all right. Clinical correlation. So we talked about Parkinson's disease, right? Degeneration of dopaminergic neurons, right? Huntington's results from a loss of ACH and GABA. Alzheimer's, degeneration of cortical and cholinergic neurons, right? So I don't want you to memorize this chart, but we're going to get into each one of these as we move forward. And it would be good to kind of go back and think about, again, reverse engineering this, deconstructing it, and saying, what the heck is going on with this disease process with the neurotransmitters? So how is Parkinson's, who presents with cogwheel rigidity, bradykinesia, postural instability, and a low tremor, why is this dude doing this? And kind of think, well, what is dopamine not doing for this guy, right? So he doesn't have enough dopamine. And then take it a step further and think, well, what medications do we use to treat that, and how does it work, right? So that'll be the whole learning process. Cerebral signs, you can star this one. You can star it now, or you can star it when we do the review. I really don't care, but you're going to get at least 2 or 3 questions on this. So symptoms localized to cerebral function, so aphasia, apraxia, neglect, extinction, frontal lobe dysfunction, or affect. So again, these are, if we see these that are going away, acutely we need to be concerned about stroke, but it could also be long-term dementia, right? So aphasia is the inability to speak. Go ahead and circle the one right under that, the bullet. A deficit in naming, or anomia, is the single most common finding of aphasic patients. If I ask you what is the single most common finding of an aphasic patient, you will all respond.
Aphasia.
Anomia. So all my aphasias, you're going to come to me and be like, you liar. So anomia. Anomia is the single most common finding of an aphasic patient. So inability to name objects, right? So and then we talked about Baroque-Wernicke's, right? Frontal temporal lobe, doing and sensing, broken versus word salad, which we hit in a second here. So I don't know. Let me see if I have. This works best for me. Again, I don't want to hide anything from you guys, but this is an individual breakdown of Baroque's aphasia and what's going on. So your non-fluent or broken speech, right? I'm not going to watch the videos, and this is a broken down slide of Wernicke's. I think it's easier to see them side by each, so I just took the 2 slides and put kind of the differences and compared and contrast them. So you'll get a question or 2 on this as well. So again, you've already had it, but it's the adult learning model repetition. That's why we're doing it. So I'd like you to know the difference between Baroque's, Wernicke's, and which part of the brain is being potentially being affected. Is that fair?
Yep.
Okay, we got some deep studying of that cards right now. So. All right, apraxia, we mentioned yesterday, is the inability to carry out purposeful movements in the absence of paralysis, right? That's a good definition. That could pop up there. I don't know if it does. Neglect, cerebral neglect, right? So what do you guys think without reading this? What is neglect, or how might a patient present if they have neglect as a cerebral sign? Not using it. So this is a drastic case, right? If you see somebody that comes in and they're not shaving half their face, or they're not putting their shirt on one half of their arm. There's cases out there in the literature that say that. It may not be that drastic, okay? Do y'all remember this yesterday? I'm going to hold it up, and like 2 of you are going to see what it is. Do you remember the pictures that we had you draw on the bottom? So I think somebody asked me yesterday, is it a pentagon? I think it's a pentagon. They were like, do I show them this and then make them draw it by memory? Nope. You can hold it there. You can have them draw it right next to it. Somebody who would neglect, what do you think their picture is going to look like? Half of it, right? They may draw half of it, or they may start to draw it and struggle through it and leave half of one of them off. Like, that doesn't seem right to me. I'm not giving you full points, right? But that's what neglect is, and that can be because of the cerebrum, or your executive suite is not working. So, okay, basal ganglia. We'll do a couple more, and then I'll break you guys. We'll come back and do this. So, We'll talk a little bit about the basal ganglia. That's where it's located. In case you didn't believe me, that's from your anatomy. Comprised of 3 nuclei deep within each cerebral hemisphere. You've got the globus pallidus and pudendum, which make up the lentiform nucleus, and then add the caudate nucleus, and you get the corpus striatum. What does this do? What is the basal ganglia? Anybody remember what it's important for? Movement. Someone said movement. I'll take movement. So coordinates motor activity. But wait a second, Rogers. You said the cerebellum was responsible for finding movement in ataxia. Get 2 things be true at once. God, I wish it was just one or the other, but unfortunately it's not. So we may see, again, dopaminergic degeneration in Parkinson's disease of the basal ganglia, and that's why you're getting that congruent rigidity and that tremor, right? Which we'll get to a little bit later. So. All right, the diencephalon or thalamus, major sensory relay, important motor or memory pathways, right? So we remember this. You guys learn this stuff or talk about this at all in endocrine?
Yep.
Have you guys clept out of endocrine yet, or are you still in it? Still in it. You're in the fight. We're in the fight of our life, right? How is endo? You like it? Yeah, it's all chemicals and hormones and stuff. Like, there's a gland here somewhere. I don't know. What am I feeling? Their neck? Am I choking? Yeah. All right. So the hypothalamus is small but very important, right? So sits below the thalamus, master control for ANS, controls pituitary function. So yeah, this is going to be important. So again, if their homeostasis is kind of out of whack and things aren't going right, we may want to scan their head and look for a tumor up there, right? So, and these can present different ways. You guys will talk about them a little bit later. We get into tumors of the head a little bit too. So. Limbic system, your amygdala, your cingulate gyrus, midbrain raphe, locus ceruleus, and hippocampus. What is this responsible for? Emotion. Good. So I got one person playing them. So emotion, eating, reproduction, right? And anybody think, well, nah, I don't know, that's not a good question to ask. But, so seizures arising, I'll just say seizures arising from the amygdala are felt as fear, so that's kind of a random one. I don't know, people are usually fearful if they have a seizure disorder. I was actually going to pivot and shift and go down a total different lane. Does anybody have little kids in here? Anybody watch Disney movies? All right, Meet the Robinsons.
Yeah.
All right, good. So I got like 2 people. The rest of you guys just tuned me out for a second. So, do you remember the hippocampus? Anybody from the movie? You tap the hippocampus. Like, all right, I'm gonna bring that one up too. All right, forget it. Yeah. So we got Waterboy. We're gonna watch Disney movies and then inappropriate movies with Waterboy. That's just not inappropriate. You guys are adults. So. All right, the amygdala responsible for fear, right? So we said here seizures arising from the amygdala felt as fear. So that would be a neat prodrome if somebody had the intense feeling of fear before they had a seizure. That would be something that could maybe they could get tipped off on, like, hey, they're panicking or freaking out, and that may be an aura to their actual seizure disorder itself. So I have not seen that out there, but it's in the literature. There's where the amygdala lives, right? Chief role in memory and emotional experiences. Central role in behavioral response to fears, right? So, hippocampus is where my diatribe went a second ago, right? So, Wilbur Robinson tapped the hippocampus with his science fair. No, nothing. All right, we'll watch it. Never mind. Stay tuned. The neat part of this, I think, is the bottom bullet. So it can predict the next event based on what already happened. So what's kind of like deja vu type feelings, like you kind of felt like you've been there, done that already, or something's already happened. You get that weird feeling. Does that ever happen to anybody? I feel like it's happening right now. I can predict that I'm going to get punched in the face by slides. Like, you know, that's happening every day. You don't have a hyper regulation of your hippocampus. So, all right, let's map the brain. We'll finish this. Cerebellum, small brain. We talked about it. 50% of your neurons in there. Anybody else impressed with that? It's tiny. 50% of your neurons or your neuronal matter. That's kind of impressive. So 10% of volume, 50% of neurons, 2 hemispheres. Blood supply. Should we know the blood supply? If you don't know it, look it up. But yeah, superior cerebellar artery, anterior inferior cerebellar artery, posterior inferior cerebellar artery. And we get into this a little bit later. But I'll tell you guys, it's important to kind of know most of your cerebellar strokes or infarcts, if they're ischemic, are going to be your PICA, because that's the first stop, and we'll take a look. That's the first bifurcation or or stop off the vascular express. So if you're like, what the hell is he talking about? I'll show you guys a little bit later. So threefold function: sensory perception, coordination, motor control. I think we hit that already. Ataxia, right? Inability to move. You see an ataxia. What does an ataxic gait look like? You guys ever seen someone that's drank too much alcohol? Also known as a killer crossover, right? You stand up and your legs are going this way, your body's going this way. No, I'm not going to demonstrate it. I'll fall and hurt myself. I know nobody here has experienced that.
Never. Never.
All right, you're not trying hard enough. No, I'm just kidding. Just kidding. All right, but an ataxic gait is so something I won't. We'll hit this a little bit later, but so somebody that's not an alcoholic drinks enough alcohol to have an ataxic gait. Your alcoholics actually get pretty damn good at hiding that stuff. So something to consider when you guys come in there is like alcohol intoxication on somebody that's not a chronic alcoholic or Wernicke's encephalopathy. They may not even have gait issues. But like you or me, if we're half a bottle deep of some rum or whatever your drink flavor is, like yeah, you're gonna have some cerebellar issues. Is that why, or that is why, when you guys, not you guys, but when they do sobriety tests on the side of the road, what are we doing?
Walking.
Doing a mini neuro exam, guys. They're doing all the stuff you guys are doing down there, like fix and follow. What are they looking for? Nystagmus. They put your foot like this and walk towards me. What are they doing? They're testing their gait, right? So the alcohol affects their cerebellar portion of the brain. Doing a roadside sobriety test is not that far off from some of the stuff you guys do. It's not as detailed. Like if they start doing like dysdiadochokinesia and finger and nose, they're a little rowdy, but they finger and nose. All right, brainstem, midbrain, pons, medulla, right? So midbrain, pyramidal and extrapyramidal functions, which are what? Voluntary and involuntary. So like movement, motor function, as well as involuntary movement, which is what? Postural adjustments. Do you guys walk around when you're out there walking around, pacing the yard? Pacing the yard. Are you thinking about like what you have to do to maintain your balance? No, your brain's doing that for you. It would drive you insane if you were like one foot in front of the other. Coordinate this muscle and that muscle. We don't do that stuff. Hopefully you're not doing that. If you are, come see me because there's something wrong with you. Spinal cord. How far are we? 51? Yeah, I get one grumbling push. I got to give you guys breaks. Let's take a 10-minute break. We'll come back and finish up. We're not that far off.
Push. Push.
Push.
Hold the line.
The problem is somebody here will
Stage 2.
As long as it's under 10, it's greater than 10.
Oh, you mean the so if we're 8:39,
Normal BP?
then if you go higher than 40 above, then
But in that first criteria, if that person but if they have
well, then that would be a different criteria. 40 and above, then
Which is
if you have like your African American, like African American diabetic, so
With
right?
high normal.
African American blood pressure.
So, why you pick this class anyway? It's pretty hard.
Beautiful view.
Yeah, it's like a
Well, there's my first science fair, the day I got my first microscope, the time I swam the English Channel, my first gold medal. Oh!
Well, by definition.
wow.
Straight jacket.
What's your average?
What are you picking out of this chart? Right corner?
When I remember, like,
I knew it's gonna be
I may have an answer.
but as I ask this question, just know that.
Okay.
Would you be open to like Madison trying to watch your dog?
I don't care.
Only because then I wouldn't have to drive twice, but I just want to know like. But I didn't know if that would be the easiest.
If you can't do it, it's because like it's really good stuff. I'll find a problem. I didn't even know.
Yeah, but
No, I can do it, but I didn't know Madison has a dog.
True, but I don't know if it's actually here.
No, I just checked her.
Oh, okay.
But I didn't tell her exactly. I
Oh.
just said
I don't care. Yeah, I don't care. So like, if so, like, that's
I
it.
just want to make sure her dog is friendly.
My dog doesn't care about it.
Yeah, but it's also her dog is friendly.
Yeah. So like, if that's the case, yeah, I don't care.
Yeah. So I haven't asked her. I just asked her what her plans were, and I think she just said like people coming over.
Yeah, I don't care. Like,
I didn't know if you would.
oh yeah, I don't care. As long as like it's just taken care of.
Yeah, because I would feel bad like going like every 12 hours.
The thing is, like, she's done it before. That's why it's not a big deal. Like, we've done it with her before, and she's used to it. She used to be a mad dog, so like, her life for 2 years, she used to literally be in a kennel all day, and like, an hour or two that the USDA requires her to be outside. It is a no. But, yeah, I don't care. So like, if that works for y'all, that's fine with me.
Yeah, I figured she already has a dog. She can get the dog from me more often. She has another dog to be around.
She actually doesn't like not like she doesn't not like other dogs. She
She's
doesn't.
not friendly.
No, not even that. Like, she's friendly with everything. Like, there's nothing she's not friendly. She just doesn't pay attention to every dog. Like, she wants to be a human. So she, like, when other dogs are around, she kind of just thinks with them. Like, they can get in her face, she's not gonna sit there, like, okay, whatever. But she wants to go and, like, be with the neighbors. Like, she doesn't really care about other dogs.
Yes. So, why you pick this class anyway? It's pretty hard. Oh, beautiful view.
Water.
All right. Y'all shut up. Last week, we talked about the physiology of the animal brain as it pertains to aggression. Now, is there anyone here that can tell me why most alligators are abnormally aggressive?
I know the answer to this question. Raise your hand.
Anybody? Anyone? Yes or you, sir?
Mama said that alligators are ornery because they got all them teeth but no toothbrush.
Your mama said alligators are ornery because they got all them teeth and no toothbrush. Wow. Anybody else? Yes or you, sir?
Alligators are aggressive because of an enlarged medulla oblongata. It's the sector of the brain which controls aggressive behavior.
That is correct. The medulla oblongata.
Mama
The
said
medulla oblongata is where anger, jealousy, and aggression come from. Now, is there anybody here can tell me where happiness comes from?
None.
Anyone? All right. Let's hear what Mama has to say on the subject.
Mama say that happiness is from magic rays of sunshine that come down when you're feeling blue.
Well, folks, Mama's wrong again.
No, Colonel Sanders, you're wrong. Mama's right.
This medulla oblongata. You don't do this like that. Coach Klein said I could. Mr. Coach Klein said I could.
Coach Klein said I could.
Alright, the other one that I was talking about right now. So you guys can talk. This is like 40
Yeah, just give me easy input. Well, now let's see. There's my first science fair, the day I got my first microscope, the time I swam the English Channel, my first gold medal for the luge. Oh, I know. Perfect. You look gorgeous. He's a lucky guy. Oh, it worked. Would you look at that? Honey, you're just in time. Lucille! You did it, Lois, you did it! This invention is brilliant! You're the spares happy.
So that's really it. It's just a snippet. He taps the hippocampus. So if you don't know what the hell I was talking about, there it is. You still should go home and watch The Waterboy. I don't know. A lot of you haven't seen it. How many people have not seen The Waterboy? Oh, just like 3 of y'all? Y'all should get together. Y'all should get together. Don't prepare to get any smarter from watching it. But it's definitely, it's entertaining. I'm not a movie critic, but Sam is my guy from England, right?
Oh, yeah.
All right, where are we at? Spinal cord? All right, back to reality here. So what were we talking about? Just anatomy, right?
The top part.
Anybody?
Yeah.
Welcome back, guys. Yeah. So we'll finish mapping kind of the CNS, PNS. So we really went through the brain itself. We're talking about the spinal cord. So hopefully none of this is new for you guys. But again, if it is, let me know. But spinal cord definition, cylindrical mass of nerve tissue, right? Has the bony vertebral column for protection. So I think good design, right? So we're not going to design, or not going to save it from like 80 mile per hour car crash, non-restrained, but I don't know. Otherwise, it does pretty good. If someone walks by you and hits you in the back, you're not getting spinal corded. So that's neat. So you guys know the segments, right? So cervical, thoracic, lumbar, sacral, coccygeal. None of that's new for you guys. Everybody remember the cauda equini, conus medullaris? Those terms everybody's familiar with. Okay, all right, far out. All right. Up and down the spinal cord, so we got upper motor neurons, lower motor neurons. Is this new for anybody? Anybody want to refresh? So upper motor neuron from brain down the spinal cord, right? So usually really long, begins in the cortex and the brain stem, travels down the spine to the level of wherever it's going to action. We're going to talk about it's going to talk to a lower motor neuron, right? So these upper motor neurons, usually from the brain down the cord, and they're going to synapse with a lower motor neuron, which is usually right here, beginning at the anterior horn, and usually starts where it synapses and then goes out to an action gland and or muscle. Does that make sense for everybody? Okay, we'll talk about upper motor, lower motor neurons, or lesions, excuse me, a little bit later, but right now it's just understanding the general pathology, the difference between the two. All right, each nerve root has a anterior, which is motor, posterior, which is sensory. Yep. We can call them ventral dorsal, efferent, afferent fibers. That's all great. I just want us to know anterior, posterior, motor, and sensory at this point. Okay? Star this one for me because this will come up later. I do want us to know corticospinal tract is for voluntary motor activity. Spinal thalamic tract, pain, temperature, light, crude, touch, pressure. And then our posterior dorsal column is fine touch, 2-point discrimination, and proprioception. Why do you think I say star that for me and I want you guys to pay attention to it? Because I'm an a-hole? Two things can be true at once. Are you guys going to be testing this stuff in clinic? Yeah, absolutely. So if you're testing somebody and temperature's off, or you have a spinal cord trauma and the temp's off, I want us to be able to at least think about, or remember that, hey, we talked about different parts of this correlating to different physical presentations. If you have to go look it up later on, that's fine. I'll keep you out of the weeds on what I want you to remember for my exam, but just know that these different tracks are responsible for different things, okay? Does that make sense? Is this repeat for y'all? Did they test you on this in A&P 1 or 2 or 7 or whatever you guys said?
Long time.
Okay. Okay. But you guys can at least appreciate why it would be important, like why proprioception, understanding that its dorsal columns would be important for you as a clinician, right? At this point, moving forward, if there's a lapse or a degradation of function, we got to understand, track that lesion and what's going on with the brain, okay? Naming the tracks, whoever did it, thank you, right? You can see the example, lateral corticospinal tract. It's in the lateral white column, begins in the cortex and ends in the spinal cord. So it's in its name. So it's actually a useful naming convention as opposed to some things which make no sense or just thrown in some sort of Latin term, right? Your pineal gland. Anybody remember the pineal gland? What's the pineal gland mean? Pine cone, right? It's pine cone. So like, awesome, thanks for that one. It doesn't help me at all. But, and it's responsible for your circadian rhythm. I think you guys said it. Okay, your motor pathways, corticospinal pathway. This just goes into each of the three that I want you guys to kind of pay attention to. So this is your corticospinal pathway, or also known as your motor pathway for voluntary movements, integration of complicated movements, and then you guys can see where it originates and descends down. If you're studying this stuff over the weekend, take a look at this slide and those three and kind of what they do. And then if you want to go deeper, here's your next deeper level that you guys can look at. So sensory, two main pathways. This is going to be your dorsal, your spinal thalamic. So it's your spinal thalamic tract. Sensory fibers enter across the midline immediately, ascend to the thalamus, in the spinal thalamic tract on the opposite side. So that's kind of neat, right? So, and then your dorsal columns, you guys, I'll pause for effect. You guys can read there. But understanding that these two are sensory, and then our corticospinal is going to be what? Motor function. Good. You guys are all on. So organization of a reflex. So how the heck does a reflex work? So we just kind of alluded to that I've got these upper motor neurons. So if somebody's telling me to do a complex movement, tell me to move my arm, then it has to go all the way back into my lower motor neuron. My lower motor neuron has to go to my spinal cord, up to my brain, and back down to tell me to move, right? So what is a reflex? It bypasses that, right? So it bypasses that. So this is a convoluted slide to show you really the one thing I want you guys to think about is this inner neuron right here, this purple piece, that when you guys are testing, so please don't hold your patient's hand over a flame to test their reflexes. That's not going to do well for you. But when you guys are doing patella, Achilles, biceps, triceps reflexes, right? Have you noticed down in the clinic or in the lab when you're trying to do this, if you're either the patient mostly and you're trying to focus on it, what happens? You can't suppress it, right? So that inner neuron, you have to distract yourself a little bit. So when you're in clinic, I know we said this last class I had you guys, but distract your patient, because if everybody's looking at your tricep and trying to get you to do it and you can't relax and you're focusing on it, it's not going to happen. So how do you distract your patient? Look away. Get them talking about something. Cup their hands, right? Pull hard, look up at the ceiling. If you're doing something in their lower extremity, it's not going to work for their arms, but absolutely. Or you can do it so quick that if they're not really familiar with your physical exam or going to the doctor's office or see your PA, you can kind of do it quick without even saying it. And they're like, oh, what are you doing? Like, don't worry, it's a normal reflex. So. But what I want you guys to take away is that inner neuron, right? That's what's bypassing that. So it's not, when you do that quick arc reflex, it's going from what you tap to the spinal cord and back, right? So it's not going up to the executive headquarters. There's no decision-making process, and you guys already know that. So spinal cord review, you guys can take a look at that, but I do want you to know motor, right? What's responsible for motor function, the other two sensory. I'd like you guys to know those three, okay? Blood supply, how is the brain supplied? Anybody, vertebral arteries, carotid arteries, that sound familiar? Why are those important for us to know? Yeah, brain flow, or C-spine, right? Prevention of injuries, right? So C-spine is a great one. But you'll have patients, and we'll talk about some disorders where they may have partial occlusion, turn their head, and they get dizzy or syncopize and pass out because there could be a blood flow restriction issue. Circle of Willis, this should be reviewed, but redundant blood supply to the brain. So we'll talk about the circle of Willis and its infamy when we get to strokes and aneurysms. It's a common place to have like a berry type or a fusiform aneurysm, but it also allows for redundant collateral blood circulation, which is good too. So posterior circulation, this is what I'll just pause real quick. Sorry I'm neglecting you guys over here, but this is what I was talking about with your posterior strokes. Usually this first stop off this bifurcation is your PICA, right? So your posterior inferior salivary artery is usually a piece of, or an emboli or something's going to come up here and get stuck, which usually your cerebellar strokes will usually be your PICA based off anatomy alone. So it's kind of worth talking about that, I guess. And how would we think a cerebellar stroke potentially present? Yeah. What else are we testing bedside? I'm going to drill you guys on this stuff. 5 motor movements. What else? Right? So all the stuff you guys are doing down there. So, and again, not everybody's going to present the same way, but that may be our only tip-off. right? So how do I know if I'm doing finger to nose, what's abnormal?
Way fast, way off.
Overshoot, right? Correction. You'll see that a lot with your drunks too. They'll be like, or they'll shake. But if you don't have a history of alcohol and your alcohol is 0 when you're doing this, and this is a new finding, it's got to be a concern. You can't write your name. It's fine movement. Right? Dystiodocokinesia is all jacked up. You're not playing patty cake well. Feel the shin, you can't do that. Walking them, they're all over the place. So be careful walking a patient you think might have a posterior a cerebellar stroke as well, right? What are you going to do? Walking around the ward, what's potentially going to happen? They're going to fall. So protection of the brain, God bless you over here. I don't know who it was, but I missed you. But wasn't as dramatic. It wasn't you this time. Yeah, I did know that much. So we know about the meninges, right? The dura mater, arachnoid mater, pia mater, right? So those are wrappings of the brain, right? We'll talk about, or you guys have already had meningitis apparently, but we hit it a little bit later as well. Dura extends all the way through the CNS, so that protective layer, right? We know that. CSF fluid surrounds the brain spinal cord. It's clear, colorless, few cells, little protein, which is helpful for us when we tap somebody or we try to do a cytology on it. How much CNF do you guys have floating around right now? It's a weird question to ask a human. A liter? God dang. About 150 mLs. Yeah. Get about turnover 30 every couple hours, I think. So it's constantly reproducing itself. But good. Ventricles, slit-like formations in the brain filled with CNS, right? So actually interesting, and I didn't tell you guys, I just kind of threw up a CT, but if you remember the first CT scan I showed yesterday, that was bleeding into that guy's ventricle, that lateral ventricle. So if you were like, why was it presenting like that? So these should typically be dark when you do a CT scan. It was white for him because blood's going to show up like that. And it's probably causing a lot of injury to some other tissues. All right, last thing we'll talk about, or I think we're getting pretty darn close, but we talked about the 2 neural tube defects. This is one, the last one I want you guys to know, encephalocele, anterior pole defect. It's the least common of the 3. And then your occipital areas are the most common encephalocele. You guys can see that baby up there is going to need some sort of corrective surgery if they survive that. Autonomic nervous system does what? Automates, automatic regulation of smooth muscle, glands, cardiac, right? Sympathetic, fight or flight. Parasympathetic, rest and digest. We good with that? No new information there. Go forth, do great things, study cards. You guys have cards tomorrow? Everybody feel good about it? Y'all are going to kick it in the teeth.